We are live now, doctor.
All right. Uh, Good evening, one and all. So, on behalf of YOSI and YOSI Retina Focus Group, I welcome you all for another exciting episode of YOSI Retina Surgical Wars. Uh, we have completed two episodes till now, and this is the third episode. So, for today's episode, we have three very young, dynamic retina surgeons. First up, we have Dr. Giriraj Vibhute, who is going to speak on a fierce and enemy and a fearless battle, a retina story. Dr. Ashul Chawla, who's going to present a video on surgical management of traumatic IOL dislocation, and a very dear friend and great presenter, Dr. Devat Shah, who's going to speak on giant retinal tear, flatten, fix, and fill. For today's episode, also we have very prominent figures in the War Council, that is Dr. Devakant Mishra and Dr. Kaushik Tripathi. Unfortunately, due to unavoidable circumstances, Dr. Mohit Dogra could not join in. And at the very last moment and on a very short notice, on a personal request of Dr. Kaushik, we are very pleased to have Dr. Atul Dhawan sir, who is a senior vitreoretinal consultant at ASG Eye Hospital, Kanpur. Thank you, sir, for joining in for this at this last moment for our webinar. And last up for the intravitreal armamentarium, we have two eminent speakers, Dr. Rahul Sharma from Star Eye Hospital, Lucknow, and Dr. Ashria Karpe ma'am from Shawfai Center, New Delhi, who are going to uh, deal with aflibercept as a case-based study in AMD and DME. So without wasting further time, I would request our first speaker, Dr. Giriraj, to please share his screen and present his video. Over to you, Dr. Giriraj.
Yes, sir. Yes, sir. Thank you. At the outset, I would like to thank organizers, ASG team, and Karthikeya and sir for this opportunity. And I'll be sharing the screen now. It's visible, I guess. It's visible?
Yeah, the screen is visible.
Okay,
The
fine.
content is
Yes.
not yet seen. Yeah.
Fine. So this was the story of a 27-year-old vegetable vendor. He had lost his other eye in his childhood. And now, following a road traffic accident, he developed retinal detachment in his only eye. This was what we were dealing with. And this is the picture which is enough to give nightmares. Retina is folded on itself and it has gone to one side and it is attached to the posterior capsule of the lens. So that is the fierce enemy and our fearless battle now begins. So initially we did lensectomy, released the retinal adhesions from the posterior capsule. You can see how the retina is folded on itself. So this is the initial view, fearsome view, but now we have to separate it. So gradually, as we gave a nick and opened the retina, you can see gush of sclerin moving out. So that is the yellowish trapped sclerin coming out. And then we are separating the folded retina from its attachments. Gradual retinectomy was done. PFCL was injected in an attempt to open the funnel, but as you can see, the napkin ring and various membranes are holding it in place, not allowing it to open. A meticulous membrane peeling was done. Slowly and steadily, multiple membranes were peeled. Wherever it was required, relaxing retinotomy was done and retinectomy was done incrementally. We injected PFCL and seen if there is still traction, then some more retinectomy was added. Abnormal adhesions were removed. As you can see, we had to fold the retina on its own, go underneath the retina and remove blood clots and PVR membranes from under the retina as well. Multiple membranes were removed in such a manner. And now, as a moment of truth, we were injecting PFCL, and for the joy of it, the retina opened well. And you can see this is the real happiness a VR surgeon can get. In spite of being a closed funnel retinal detachment, we could settle it. And after fluid air exchange, this is the final view, which was a site for our sore eyes. And silicone oil injection was done in this patient. This is the 10 days post-op image. And this is the pre-op and post-op image compared from PLPR. The patient is now 6/36. Remember, he was a one-eyed patient, none-eyed patient actually, Now he is able to walk on his own, and he is real happy. So the take-home message from this case is closed funnel RD is not a dead end. With modern technology and techniques, the cases which were earlier thought to be inoperable, they can be given a try. So let there be hope. So yeah, that was my case, and thank you.
Very well done
Excellent case,
surgery.
Dr. Giriraj.
Thank you. Thank you.
Nicely recorded and very well documented also, and very well done surgery. Now I open the discussion for the panel. I would invite Dr. Ratul's comment, please.
Excellent surgery, really
Thank,
beautiful, and he has done a great job by removing all the membranes and settling the retina. I have no words for this surgery. Commendable job.
thank you. Thank you so much, sir.
Dr. Kaushik.
Excellent surgery. Basically, this was a very difficult case and managed very nicely. So my comments would be, if it is aphakic, it is better to put like inferior PI,
Yes.
Andos PI, which was not done. And also sometimes because there was PVR membranes and there was a large retinectomy, if you do fluid air exchange, then the flap can actually slip. So
Yeah.
it could have been better to go for direct basically PFCL oil exchange. But this surgery was definitely done very nicely and commendable work.
Thank
Excellent.
you. Thank you,
Thank
sir. PI was done in the end. I have not included in the edited version. But yes, the point of direct PFCL silicone oil exchange is well taken, sir. Thank you.
Because sometimes it slips actually.
Yeah.
You are lucky that it did not slip, but once it slips, it will add to the time of the surgery and media will become hazy and some other problems will start.
Yes, sir.
One point is if you can add a 240 band with that, is advisable or buckle with that.
But we are doing 360 retinectomy. I don't
Yes.
know how much.
After retinectomy, you are actually sacrificing the peripheral retina, then there is no point putting a band. But basically nothing is there to support there.
No,
Dr. Devapan.
but what is the
Yes.
but what is the use of 240 band here?
And that's what we are telling. It could not be helpful here when we are doing 360-degree retinectomy.
Yes, Dr. Giriraj, great case. As everybody said, nicely documented and operated upon. I agree with Dr. Kaushik about the direct, PFO oil exchange.
Yes.
That's an excellent technique in these cases. My question would be, these extensive detachments and retinectomies do end up with a lot of PVR. So
Yes,
did you
sir.
did you consider any adjuvants, to prevent that post-operatively?
Nowadays, we are considering according to GUARD protocol, methotrexate injection, sir. We are conducting our own study on that. So as of now, the first patient is in his way, but we don't have results of our own to show as of now.
So this was not the first patient, right?
No, sir.
Okay. Okay. So I think that is when we have that data from you guys.
Yeah.
Dr. Srinivas was there in one of our
Yeah.
previous sessions. He was telling us about the
Yeah.
modified guard.
Yeah.
that you
We
guys-
are working.
So look forward to that data. And
Sure,
great, wonderful case. Thank you.
Thank you, sir.
And also the way you handled, like you did bimanual dissection, that was also great. Very nice.
Thank you, sir. Thank you.
I think we shall move on to the next speaker. Next up, I would like to invite Dr. Ashul Chawla to please share his screen and present his video.
So, good evening, everyone. I am Dr. Ashul Chawla from Bhopal. Thank you for hosting me here. And would like to give kudos to Dr. Giriraj, a very good case. So, let me begin with my video. It's a voiceover video. So, Shankar Nital. Is the audio audible? I am Dr. Ashul Chawla, a 6-month eliminate
Your video is not visible.
currently working with my dad. Sorry, sir?
Dr. Asul, please share the
We
video.
can't see the video yet.
Oh, sure. Yes, one second.
Reshare the screen.
Yes, sir. Is it visible now, sir?
Yes, just make it
Yes.
full screen. That will be great.
Yeah. Yes. Good morning, everyone. I am Dr. Ashul Chawla, a 6-month alumnus of Shankar Nethralaya, Chennai, currently working with my dad at Vision Care, Bhopal. First case is of a 52-year-old man with a vitrectomized eye, having trauma followed by dislocation of single-piece acrylic lens, limited paratomy at 3 and 9 o'clock, cautery to the bleeders, 2 by 2 mm partial thickness flaps, and scleral pockets using bent MVR 23 gauge. Since the patient also had risk of angle recession, we decided to preserve the superior conjunctiva. This located lens is held with intraocular forceps in the dominant hand. A 3 mm clear corneal entry is made with non-dominant hand, and the IOL is transferred to the McPherson's, which is then in turn brought into the AC. Now the haptic is externalized. With a constant pulling over the haptic, the optic is cut using one scissor. This is called the Pacman technique of IOL removal. Now a three-piece lens is loaded. The leading haptic is fed into the bore of the needle, which is then externalized. A stopper over the needle is then transferred to the leading haptic for easy manipulation. A 25 gauge trocar is used to make entry at 9 o'clock, and the intraocular forceps used to externalize the trailing haptic, which is then dug in the scleral pocket. Leading haptic is also tucked. Thus, you have IOL removal and a three-piece SFIL implantation all done from a 3 mm clear corneal incision. So next up, a case of a 57-year-old gentleman with a displaced three-piece lens. Now, similar to the previous case, scleral flaps and pockets have been made at 3 and 9 o'clock. Anterior vitrectomy is performed, followed by core vitrectomy and then base excision. While performing the vitrectomy, one of the haptic got dislodged. The dislodged haptic is retrieved with the intraocular forceps in the dominant hand and then carefully engaged 26 gauge needle in the non-dominant hand. The haptic is then externalized and secured with the stopper. Trailing haptic had adhesions in the cell structures. So the cost to free the adhesions, trailing haptic is then analyzed from 9 o'clock using forceps and then tucked into the scleral pockets. Conjunctiva is closed with the glue. And thus we have the internal refixation of the same three-piece IOL. The next case is of a 63-year-old lady who came to our OPD at Vision Care Bhopal.
I think there's some network issues at Dr. Chawla's end.
Yeah,
Hello?
the video is not there.
And while it was playing also, I think it was not
It was there was
connected
lag.
to a proper network actually.
Yes, I think the
I will
second
call him.
video
I will
will
call
not
him.
make.
Yes, we can take the next candidate.
You can take the next.
Yeah.
I'll call him.
Next video, yes.
Dr. Devat, are you there? Yeah. Can you please share your screen?
Sure. Hi, everyone.
Hi. Dr. Ashul will take the video probably at the end after this video. Maybe you can work on the network till then because your network was also weak while you were playing the video.
Okay, sir. Sure.
All right.
I'll check. Yes. Hello. Yes, sir.
Hi. I think the screen is visible, right?
Yeah.
Yeah. So one more detachment, one more thrilling video. Here it goes.
Tighten your seatbelts because you are about to witness a surgical journey like no
The
other.
video is not
Dr.
visible.
Devat, it is not
Take your
playing yet. As in
The
we are
screen
still
is
on
not
your list of videos actually.
Extensive list of videos.
Yeah, happy to see all of them.
Playing at my end. Sharing my screen again. Yeah.
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 Awesome. Yeah.
Tighten your seatbelts because you are about to witness a surgical journey like no other. An 8-year-old girl, one-eyed, intellectually disabled, and her only seeing eye suddenly goes blind. Her mother carries her in her arms to us, desperate and helpless. Her right eye was already damaged since childhood, and her left eye, the only seeing eye, has no vision and a hazy view. B scan shows an astonishing giant retinal tear spanning over 300 degrees, and her only chance was a vitrectomy with a complete PFCL fill, endolaser, and silicone oil to keep that fragile retina in place. Imagine the little girl's plight. Her world has suddenly gone dark, and all she has left is faith. We started the miraculous surgery with a 25 gauge 3-port hypervid system and carefully cleared the anterior vitreous. Moving to the posterior, I was greeted by the sight that would make any retina surgeon pause. A retina that was folded like a taco. As I worked the vitrectomy, I suddenly saw some white matter coming in the cutter. And it was unusually not the lens matter, but the peripheral retinal frills that were being sucked inside the cutter. Hence, I lowered the vacuum and stained the vitreous with triamcinolone. With extreme precision, I continued with the vitrectomy. My view was still extremely hazy, so I did what all retina surgeons love to do. I scraped the epithelium off to improve my view. And now, there it was, with an improved view, a retina, folded like a taco. But the problems don't stop. And I saw that the retina was actually torn from the temporal end. Along with the tear, there were multiple breaks and holes and lattices in the periphery. And that might have been the cause for such a magnanimous giant retinal tear. Hence, I choose a direct PFCL fill, allowing the retina to settle under PFCL like silk draped over glass. Once the retina was absolutely settled under PFCL, I re-examined all the periphery. And to my surprise, the retina was not only torn, but it was folded and wrinkled. Hence, I turned to my ultimate tool, the 25 gauge hyperwit cutter with a beveled edge, and I actually used it to iron out the retinal fold. A moment, nothing short of magical. So you can see the fold unfolding, and now the retina is absolutely settled under PFCL. With the retina finally on, it was time for a 360-degree endolaser. And in these cases, 4 to 5 rows of endolaser are usually required to secure the retina to prevent any chance of having a redetachment. After the endolaser was done and the retina was beautifully settled, I conducted a direct PFCL oil exchange. That is, I injected 5,000 silicone oil from one end and simultaneously I extracted the PFCL from the other end under direct visualization with the help of a fluid needle. I had to make sure that I leave only the oil inside and no PFCL. And I was able to succeed with that maneuver. And you can see the PFCL bubble going down in size. And now the retina looks absolutely wonderfully settled under silicone oil. I took a deep breath and started praying to God to restore this little child's vision. A week later, she came into my OPD, a miracle in motion. She walked in all by herself, independently, eyes clear and vision restored. She hugged me and said, "Doctor, I can see the TV again." And on examination, her retina was beautifully settled as evident on imaging. This wasn't just a regular surgery for me. It was a testament to trust, resilience, and a desire to restore vision by a massive conquest. Thank you for your time.
You have to say great video again. I am still learning those Filmora effects which you have already put in so many ways. All right, great video. I
was
would
right there to
request the
see the patient
panelists to
also. Yeah.
please comment on the video. Dr. Atul sir.
Yeah, again, it's a very good surgery. Very good surgery. A
Thank you.
young girl, 8-year-old, and a giant retinal tear, beautifully managed.
Thank
Superb
you.
surgery.
Thank you. Thank you so much, sir.
Dr. Kaushik.
Excellent surgery. Very nice. Actually, it was managed uh, excellently. So I have one or two comments like mental retardation we are not using currently. It is better to tell
Correct.
intellectual
Physically
disability.
challenged.
Challenged or intellectually challenged.
Intellectual disability.
Yeah,
So
so
it is
now
not
in the
mental retardation.
now in the Western world, they have shifted from intellectually disabled to now they call them people of determination. So that is something new which I have learned.
Yes. So basically, and
Yeah.
like how did you manage the intraocular pressure when you are injecting PFCL?
So
I
whenever
wanted to
I
ask the
inject,
same.
so whenever I inject PFCL, I lower my IOP to 25, and if I'm doing a complete fill, then I lower my IOP to 20. That is how I do it. And I don't use the automated system from the Constellation. I ask my assistant to hold the silicone oil, and from the other end, I start injecting, and I use the flute needle along with my light pipe to use it. There's also a machine variation in the Constellation. We can even you can directly do a PFCL oil exchange.
Yeah, there is a setting for that.
There's a setting for this is actually an old video. So 6 months back we did an SOR for her. So now she's maintaining 636, 660 partial. She's going back to school. So now I have been using the automated system. Previously I used to use the manual one.
Yes, and there was this radial kind of tear or rip
That was
which
very
can be
unfortunate.
seen in this. And another thing is if child is bilaterally has retinal detachment and is mentally retarded, then you'll have to search for whether there is any genetic syndrome or anything associated with that. And other thing is if such but the child has a nystagmus, the silicone oil emulsifies earlier than what we usually see. So that
Yes.
is another thing which we need to
Exactly.
take care.
That is exactly the reason why I used 5,000 and not 1,000.
Yes, yes. Excellent surgery. Thank you.
Thank you very much.
Dr. Devaka.
Yes, I think Dr. Kaushik, apart from, appreciating Dr. Thevat, I would appreciate Dr. Kaushik also. He has covered all the points that I had in my mind. So again, Dr. Thevat, beautiful surgery and wonderfully managed. And uh, in such cases, we also have to be lucky, right? So that the patient
Absolutely.
does well. And, with similar cases, I have not had as beautiful results as you have had. So congratulations and, best of luck. Yeah, thank you.
Thank you, Deva. Thank you.
Dr. Ashu, are you there? Can you share
Yes,
your
sir. Yes, sir.
All right.
Yes. Okay, sorry for the technical glitch. I'm going to replay now. Good morning, everyone. I am Dr. Ashul Chawla, a 6-month alumnus of Shankar Nethralaya, Chennai, currently working with my dad at Vision Care, Bhopal. First case is of a 52-year-old man with a vitrectomized eye, having trauma followed by dislocation of single-piece acrylic lens, limited peritomy at 3 and 9 o'clock, cautery to the bleeders, 2 by 2 mm partial thickness flaps, and scleral pockets using bent MVR 23 gauge. Since the patient also had risk of angle recession, we decided to preserve the superior conjunctiva. Dislocated lens is held with intraocular forceps in the dominant hand. A 3 mm clear corneal entry is made with non-dominant hand, and the IOL is transferred to the McPherson's, which is then in turn brought into the AC. Now the haptic is externalized. With a constant pulling over the haptic, the optic is cut using Warner scissor. This is called the Pacman technique of IOL removal. Now a three-piece lens is loaded. The leading haptic is fed into the bore of the needle, which is then externalized. A stopper over the needle is then transferred to the leading haptic for easy manipulation. A 25 gauge trocar is used to make entry at 9 o'clock, and the intraocular forceps used to externalize the trailing haptic is then tucked in the scleral pocket. Leading haptic is also tucked. Thus, you have IOL removal and a three-piece SFI implant implantation, all done from a 3 mm clear corneal incision. So next up, we have a case of a 57-year-old gentleman with a displaced 3-piece lens. Now, similar to the previous case, scleral flaps and pockets have been made at 3 and 9 o'clock. Anterior vitrectomy is performed, followed by core vitrectomy and then base excision. While performing the vitrectomy, one of the haptic got dislodged. The dislodged haptic is retrieved with the intraocular forceps in the dominant hand and then carefully engaged into the bore of 26 gauge non-dominant hand. The haptic is then externalized and secured with the stopper. Trailing haptic had adhesions in the sulcus structures. So the cutter is used to free the adhesions. Trailing haptic is then externalized from 9 o'clock using forceps and then tucked into the scleral pockets. Conjunctiva is closed with the glue. And thus, we have the internal refixation of the same 3-piece IOL. The next case is of a 63-year-old lady who came to our OPD at Vision Care Bhopal who had a diminution of vision after a fall. Patient also has a history of recent cataract surgery at a government hospital. She did not have any documents regarding her surgery. On slit lamp examination, we could see the capsular rim, eccentric pupillary dilation, and a rigid PMMA-like reflex which was partially dislocated from the nasal side, and overall fundus was within the normal limits. So a routine IOL repositioning surgery plus minus IOL exchange was planned. After connecting the infusion, the pre-existing tunnel was reopened, and we could notice an IOL reflex in the retroglow. So it was supposed to be a routine in and out job. While explanting the IOL, I could notice some amount of unusual tug on the iris. It made me think probably the haptic must have adhered to the sulcus or the iris tissue causing the pull. So I decided to change my angle of attack, trying to externalize the dislocated haptic, assuming that the trailing haptic will be easy to maneuver if the majority of the lens is out of the vitreous cavity. So let me pause here for a second. If we appreciate the outline of the lens now, to our surprise, indeed, it was a retropupillary iris claw lens. Trauma must have caused the haptic to tear a small chunk of posterior iris and in turn dislocate posteriorly. Now, knowing this, I took a second to think about my options here. Should I refixate the displaced iris claw, but with the risk of it again getting dislocated as the optic or the iris site might have been damaged? Or should I disenclave the other haptic also and explant the iris claw proceeding with the IOL exchange as planned? Or the third, hand over the case to my dad. Well, I went with the second option. So the idea was to gently nudge out the iris out of the haptic. If it comes out easily, then okay. Otherwise, to break the haptic and remove the lens. But as I tried to pry out the iris, I could notice an early iris root dialysis. Hence, I decided to abort the plan and cut the iris tissue out. You can notice that as soon as the cut is made, the lens pops out. As you see, the leading haptic of the lens was compromised. So the attempt to reposition the iris claw lens would have been catastrophic. After this, a complete 3-port vitrectomy, anterior, core, and IVT assisted PVD induction was induced. Visco injected behind the iris in the sulcus, then a multi-piece lens is placed into the sulcus. The optics were trapped behind the excess margin. Tunnel is then sutured and sclerotomies were self-sealing. Yes, sir. So that was the
Great video. I think great compilation of all the complicated SFILs or 3-piece ILs or complicated cataract surgeries. I would like to open the discussion with Dr. Devakant if you would like to come in.
Yes, great compilation, Dr. Ashul. So, what is your preferred technique usually when it comes to secondary eye implantations?
Sir, so what we have now moved on to is a mixture of Yamane and X-knit technique. So the tunnel is made like an X-knit, but the side we do not do the peritomy. We directly do the Yamane type fixation, and we carry that IOL loading outside in the from the tunnel. So all the loading and everything, a whole circus goes on outside of the eye, not in the vitreous cavity. So it can also be done with the limited anterior vitrectomy and then can be proceeded with the SFIL fixation, sir. So it's a modified Yamane X-knit technique, sir.
Great. I mean, there's so many variations of these techniques,
Yes.
and again, it boils down to what one is comfortable with. So I feel, I mean, as a panel, we can always discuss, which technique is better, but beautifully managed. All the cases were nice.
Thank you, sir.
And yeah, great. Thank you.
Thank you, sir.
Dr. Atul?
Uh, I usually make that side tunnel for the haptics is not from the MBR blade, because by creating with the MBR blade, the width of the tunnel is very much, means it's very broad. So we usually do it with the 26 gauge needle, bent 26 gauge needle, and that is enough for this haptic fixation.
Mhm.
So
So do you also use glue after the fixation? Do you use glue for the flap?
I think we are doing from the last 10, 12 years, same technique, glue dial.
Glue nail.
That,
Okay.
that's why.
Yes, yes.
So we all are very much comfortable with the glue dial technique, and this fixation with the 26 needle, the chariot pocket, it's more than enough
Yes,
for
yes.
this,
Mm.
for haptic. The more width can lead to the movement of this uh, haptic.
Yes,
So
sir.
that's why we are not using it.
Yes, sir.
Right. Any other panel would like to comment?
Dr. Rasul, very
Dr.
nice
Atul?
surgery. Very nice surgery. So I had a question, like, was the first case vitrectomized?
Yes, sir. It was a vitrectomized eye
Hmm.
that I'd mentioned in the voiceover that it was a vitrectomized eye, and then they got dislocated. That is why it was possible to capture and bring it out.
And you said the like haptic got broken. No, now what happened to the haptic? Actually, I could not understand.
Okay,
The,
sir.
Hmm.
In the second case or the first
Yes.
case?
Second case.
Second
Second
case,
case
sir.
or third case, there was a broken haptic or something.
Yes, sir. So, sir, second case, there was a three-piece IOL. It was already fixated elsewhere. So it got, displaced, dislocated. So when I was doing the vitrectomy, anterior vitrectomy, the leading part of that haptic fell down. So I had to retrieve it after completing the vitrectomy.
Was it separate from the optic or it was attached to the optic, but just
So the whole system, the three-piece whole IOL fell down.
okay, okay. Okay, no, sometimes what happens is that if you pull it much, then the
Okay.
haptic can get broken from the optic. I
Yes.
was thinking of that. It did not happen, no?
No, sir, no, sir.
Yes, yes.
I
In
also had one case, sir,
Hmm.
in which the haptic got broken where I was externalizing the
Yes.
optic when I was in my fellowship day, sir. So my consultant at that time told me to suture it with a Vicryl, put a X knot at the broken haptic rather than tucking it in. So put an X, that infinity suture over that haptic, and it was quite stable, sir. Till the follow-up, we were seeing the
Uh,
patient.
there are certain lenses which are like Orolabs
Exactly.
foil lens. It is a little sturdy lens. Otherwise, this Alcon multipiece, etc. It actually breaks if you do not maneuver it properly.
Yes, sir.
But very nicely done. Very
Thank
nicely
you,
done.
so much, sir.
Thank you.
Thank you, sir.
And another question is, if there was a sulcus, like you in the last case, you said that there was a sulcus, no?
Yes, sir.
And you could put multipiece IOL in the eye, but the initial surgeon planned to put
Iris glow.
iris claw lens.
Yes,
So
sir. Yes, sir. We also had a doubt on table. That is why we were not expecting it to be. We were not expecting it to be an iris claw, and it was a surprise for us too, sir.
basically, during surgery, sometimes yeah, or something may not allow the surgeon
Yes, sir.
the to assess what is the status of capsule. I think the surgeon may have been more comfortable with putting an iris claw.
Iris glow. Yes, sir. Yes, sir.
Okay. Thank you. Very nice.
Sir, I had one doubt, sir. What could have been done? Could the surgery be proceeded in a different way rather than cutting open the iris? Could it have been done in a different way?
It was like as you showed now, it was stuck. Basically, when you were pulling, your other hand should have been in the iris where the enclavation was done. And
Okay.
basically, though it is easy to say, but it is difficult to do because some both eyes and the eye gets distorted, and it is very common to have a like this thing hydrolysis which you had. But I think that plan you did was a good plan, because and it is also very difficult to see whether the enclavation, the area for attachment of the retroclaw is actually present or not during surgery. And
Yes.
these people have hazy cornea. It was a good idea to take it out
Okay,
and
sir.
then put a second different lens. Different lens can be of different, could have been differently, but because the sulcus was there, I think you did a good job. Very nice.
Thank you so much, sir.
And you called your dad. That is a good thing. But in any case, if you are feeling that you are stressed, I think it is a better idea to call somebody who doesn't have the same stress and who can manage it afresh.
Yes,
So
sir.
it helps the patient, and ultimately, which is our goal, to give the patient a good outcome.
Yes, sir. Yes, sir. Thank you, sir.
Wonderful cases, wonderful presentation. I think we have also had very good discussion as well. We have come to an end of the video presentation. Before we move on to the further talks, I would request all the panels to please calculate the score and probably message me, Kartikeya or Dr. Kaushik once. And now I would like to invite Dr. Rahul Sharma sir, who's a consultant and head of Star Eye Hospital, Lucknow, to please share his presentation and deliver his talk. Over to you, sir.
Yeah, thank you, Kartikeya and Dipanshu. I'm Dr. Rahul Sharma. I'm going to present. I'm a veterinary surgeon and I'm MS from KM Hospital, Mumbai. And I will be presenting my three cases, if time permits. These are the two of ARMD cases and one of diabetic macular edema. I think the slides are visible.
Not yet. Yeah.
Yeah, thank you, Bear and Yosi, for giving me the opportunity. First case, I'm start with the 58 years female patient, resident of Kanpur, complained of both eye decreased vision for last 2 years, but she was not getting the proper treatment and she was getting some amount of oral tablets, Ayurvedic medication for last many for these 2 years, and her vision was gradually deteriorating. But the only thing is she was already complaining to many ophthalmologists. She was having a distortion which was not picked up by few of many of the ophthalmologists, and her vision was 660 and 630 in the left eye. Pressures was normal, and this is the anti-segment photo of the patient. Both eye was pseudophakic. Even the capsulotomy was done, and the vision was not improving previously. And when she came with me, this was the fundus photograph. In the right eye, there was a the subretinal membrane with active exudation on the right eye. Left eye, I thought it is more is a clean eye, and it doesn't have that much activity. But to my surprise, when I did the OCT, it was showing much subretinal fluid and a CNVM complex. And the right eye had a very big membrane with thickness of the macula somewhere around 380, 359, and the symptoms were correlating with the uh, uh, ARMD features. So after the afflebar set, the exudation has gone down and the membrane got more organized. Even in the left eye also the symptoms and the feature has improved, the picture improved. And after the OCT finding, we saw that it is decreasing, and the patient had a very the distortion has gone. She was more happy. We have a change analysis in the Zeiss society, which give me in these patients sometimes we are not able to convince the patient whether they are improving or not. So these are feature which I got in Zeiss, which when I show these patients, yes, definitely metamorphosis is changing, but at certain point of time, these OCT finding will always help you to make the patient realize that yes, you are improving with time. So this was the first. In the left eye, change in analysis was done. That was also improving. So vision improved by one line and decrease in the symptoms of metamorphopsia. And she was followed by next two more injections. At the end, this was the picture, which is the exudation has decreased to a greater extent, and the lesion become more organized. And at the end of the fourth dose of anti-VEGF aflibercept, I thought better to go for home monitoring with Amsley, because even after 3 doses, the OCT was showing all dry features. There was no activity, so the symptoms were all gone. The second and the second thought came to me, is whether we should go for the 3 loading dose as the protocol says to us, or should I start from the PRN from onset. Few cases respond very well with the even first or second dose. The third dose, maybe we can postpone or do a PRN regime from the first or second dose also. In the case 2, same of ARMD, a 75 years old male patient resident of Mau had he was an engineer by profession. So same distortion of images for a few months, but he was not so happy because he already has received ranibizumab 3 ranibizumab intravitreal injections, but he had lost the confidence in the intravitreal injections. So although his elder brother was also having a patient of wet AMD, his vision in the right eye was 6/9, left eye was finger counting 2 meter, pressures was normal. This was the condition anti-segment photo of the patient. Right eye was NS1 2 cataract, left eye pseudophakic. You can see the drusense in the right eye and left eye. This is after giving the ranibizumab injections, after 3 ranibizumab injections. So he waited for a few months before deciding for further injections. So when he came with again, the exudation has increased in the left eye, but that it was like a dripping appearance to me. So I thought I could keep a differential diagnosis of a chronic CSR or a variant of ARMD like PCB. When I did a OCT, the double hump sign was seen. So it confirms the diagnosis of PCB and AMD. So now he was convinced that his vision was decreasing day by day. So we went with the at that time it was post in the era of Corona. So aflibercept was not easily available, and it was like pilot project in India. So I tried to convince him that yes, we have new molecule and which will going to act better. So we started with the aflibercept and gave 3 injections, and after the 3 injections, the result was that it was totally dried, and the symptoms has gone, and he was happy with that. And now at the end, in the year of 22, he received 4 injections in the left eye and 4 more injections in the year 23. To the surprise, because the right eye developed, he again became very much apprehensive when his right eye was involved. He was in Delhi. So I just thanks to ILEA for you program, because I just shared the code which was available with me to a retina surgeon in Delhi, and he got the injection there itself. And further, when I saw him, the right eye lesion was decreasing. So I did the OCT was showing the undulation and uh, some amount of edema in the temporal area of fovea of the macula. So vision was the 612 in the left eye, right eye, and 660 in the left eye. And right eye received a number of somewhere 5 injections, and in the year 24, now his 17th injection is scheduled. Now I'm also stressed him for the home monitoring and OCT finding. So further injections, I think, will be correlated with the OCT and his symptoms. But at least he's till now, in the last 4 years, he has received somewhere 16 to 16 injections, and he's stable and is seeing with the only right eye. Case 3, a 53 years female patient resident of Lucknow. She's a diabetic on insulin and oral hypoglycemic, and a hypertensive since last 25 years. So she came with a finger counting 2 meter in right eye, and left eye was 636. No improvement in the right eye. Pressures was normal. This is the anti-segment photograph of the female patient. Right eye was showing very less cataract, hardly NS1 cortical, and but the vision was finger counting 2 meter. And the left eye, the lens was clear, and the finding was suggestive of moderate NPDR with diabetic macular edema. Definitely, the right eye with such a cataract, the vision 2 meter is not justifiable. So always when we do a workup, we should always do a pinhole vision, or why these diabetic patients are not improving. So we have to look at the fovea, which was dull in the right eye, and slight reflex was there in the left eye. on the OCT where classical spongiform edema on the OCT with neurosensory detachment was seen, and I gave anti-VEGF, and she came after 10 days, and I usually follow this patient to just to have the effect, whether the what is the peak duration of action of these drugs, so that I can document them. On the 10th day, I saw some definitely the edema has gone down, and after that she was so happy that she didn't came for a regular follow-up, and she came on the almost 50-55 days, and at the 55 days this was the OCT. The right eye was very much reduced edema, and left eye was having some parafoveal edema, which was she was maintaining 6 time vision in the left eye. And after this, I thought, okay, I may postpone further injections, but sometimes we are having that pressure that at least 3 loading dose should be given. So I gave the second dose, and now she's following with home monitoring with Amsler and an OCT follow. So as per need, in this case, I have not given a regular 3 loading dose, but try to postpone it as per patient need. Thank you, sir.
Dr. Rahul, what is the diagnosis in the second case?
Sir, it was wet AMD. OCT was going double hum sign, goes in favor of PCV, sir.
I think what you are telling, double hump sign, it is a sets of CNVM, not the double hump sign.
Okay, sir.
Thank you, Dr. Rahul. Those were some great documented cases. I think before we move on to the next talk, I would request Mr. Sai from Numerotech to please share the polling so that we can have audience poll for the videos that have been presented in today's presentation, in today's episode. Ms. Manjula or Sai, are you there? Yeah.
Has everyone answered? Not yet.
I think so.
Yes, yes.
Everyone has answered, I think. I think we can end the poll and move on to the next talk by Dr. Asya Kartin, ma'am. She is a consultant veterinary services at Shroff Eye Center, Delhi. Over to you, ma'am, for you.
Thank you, Dr. Dipanshu. Good evening, everyone. I'll just share my screen. So I'll be presenting 3 cases based on my experience with aflibercept. Aflibercept, as we all know, has received FDA approval now for all possible retinal conditions. In the first case, we had a 79-year-old female who came in January 2022. She was a bilateral pseudophakic, a hypertensive, and she came with history of decreased vision in the right eye since the last 1 year. She was quite disappointed because in spite of having multiple injections of ranibizumab, she did not show any improvement in her vision. When she came, the vision in the right eye was 618 parts N10 and in the left eye was 66 by N6. So this is the OCT image at presentation. So here we can see a typical type 1 CNVM with subretinal fluid, quite a prominent network on the OCT-A. Left eye was essentially within normal limit other than a small drusen. So she received her aflibercept, and After one injection of aflibercept, after 2 months, we can see there has been a significant improvement in the subretinal fluid, although the network has seemed to become a little more prominent. So she went ahead with the second injection because she saw an improvement in her vision. After 2 months of the second injection, her vision improved further to 6, 9, and 6 parts. The fluid had reduced further, the size of the PED was also less, although the network again seemed to become a little more prominent. She was then lost to follow because she had to undergo some other surgeries. So when she came back 4 months later, fortunately for me, the network had not increased that much, and even her vision was pretty much stable at 612. So we went ahead with further injections. She got one after 2 months. On 9th of February, again, she showed very good response. So multiple injections at interval of about 8 to 10 weeks. We tried treat and extend, but we couldn't extend her beyond 10 weeks. Finally, after 18 injections and at keeping her at an interval of about 12 weeks now, her fluid has reduced to a minimum. The network has become very prominent, but she's very happy because her vision has improved to 6, 9, and 6 parts. And she's pretty much asymptomatic on the distortion front. So in the second case, we had a 57-year-old hypertensive male who came with a history of decreased vision in the right eye since a week. He complained of seeing a large black spot which appeared all of a sudden. The vision in his right eye was 6/60 and in the left eye was 6/6. He did have a central PSC, but that was not really contributing to the extent of vision loss. So this is the color fundus photo. We can see there's a large subretinal heme involving the macula and extending inferiorly along with some subretinal fluid. This is the OCT picture, very dramatic looking picture with large mounds of subretinal heme, including subretinal fluid. The left eye was essentially within normal limit. So we went ahead and did a TPA gas and Eylea injection, counseling the patient that there would be a risk of a breakthrough heme in case of such large bleeds. This was day 1 post TPA gas. We can see the gas bubble. There's not much displacement, although the patient did say he did lie down prone, but there is some clearing of heme temporal to the macula. Day 2, we were very happy because the heme seemed to have displaced periphery. The central was better. The patient was also a little happier. So we sent him home, told him to come back in 2 weeks. And the patient comes back 10 days later with a large vitreous hemorrhage and a subhyaloid hemorrhage, and pretty disappointed. But since we had already counseled him, we went ahead and did a cataract extraction with IOL with a vitrectomy and endolaser. The post-op was pretty uneventful. Patient was okay. Came back 1 month later. Vision had improved to 6/18. The media was clear. We got an FFA ICG done. Did not see any recognizable laserable polyps. So we went ahead and continued with the injections. He received 2 injections, 2 monthly. And this was his latest follow-up. Looking at this picture, we were quite happy because patient was also very happy. His vision had improved to 6/6 and 6. There was a little bit of altered subretinal heme still persisting, but it was not troubling him. We decided to repeat an Eylea after 3 months. And so this was the image. This was at presentation. This was 2 weeks post vitrectomy. We can still see the CNVM. And this was the latest photograph where there's complete resolution of the fluid, the network, the PD also seems to have completely disappeared. So in my third case, we had a 76-year-old hypertensive female. She gave a history of receiving Eylea in both the eyes, 1 each, but she came to us with a sudden loss of vision in the left eye. She also was a bilateral pseudophakic. The vision in her right eye was 6/24 and 10, and in the left eye was 6/60. So this is a color fundus photo. The right eye, we can see there is some RP abnormalities. The left eye, however, had a more dramatic image. Again, there was a large subretinal hemorrhage, which was extending into the inferior retina. Now, because of her age and certain back issues, she was not able to position. So we decided not to go ahead with TPA gas in her case. We decided to continue with the injections. After 2 aflibercept in both the eyes, the right eye was quite stable. Her vision had improved to 6/12. The left eye, unfortunately, did not follow the same course. It was a little disappointing for the patient as well, because the central network seemed to be scarred and she developed a large rip, which, although the heme was absorbed, but the rip did not make the patient very happy. So after the third injection in both the eyes, we did not see any change in the left eye. The right eye was, however, stable. The network had decreased, the fluid was absorbed. So we decided to discontinue the injections in the left eye. In the right eye, she is currently on treat and extend. We have managed to extend her up to 10 weeks, 15 injections in the right eye so far. And because she's essentially one-eyed now, we're continuing with a slow 2-weekly extension. The left eye, we stopped giving her injections after 4 years. Her latest follow-up, her vision was 6/12. She occasionally sees in the left eye 6/60 with an eccentric fixation. So to conclude, aflibercept is very effective for wet AMD, PCV, and DME. It is important to know that it is a tool which has to be individualized. We cannot follow a strict regimen. And of course, in spite of giving multiple injections, we need to persist and need to counsel the patients that, it is a long road ahead. Thank you.
Thank you, ma'am. That was a wonderful talk. Any comments from the panelists, Dr. Kaushik, Deva?
Very nice images and very nicely managed. Specifically, RP rip was like huge, but matlab, hopefully it was not in the center of the like in the fovea. And I was already damaged. And ma'am, another question was that sometimes people say that aflibercept might not work if it is given with TPA. So what is your clinical experience, or is its activity reduced when it is given with TPA?
It is often said that Eylea may not be the best choice with TPA, but I don't think we've had any adverse, effects so far. We've been quite happy with it, and usually we give it. It also depends on the patient, obviously, what he
And
chooses.
also another thing is after TPA in submacular hemorrhage, it is not very uncommon to see bleed. Actually,
Yes.
It happens, and
Yes, it's very common. That's why we had
Yeah.
already counseled the patient beforehand, because we were pretty sure that it would bleed. But in our case, fortunately, the patient did regain a very good vision, which is very uncommon actually with such large bleeds, because usually they do end up with a central scar.
All right. If we don't have any more comments, I would like Dr. Karthikeyan, shall we announce the results and
Yeah.
further? Yeah. All right.
So it was a very great cases, all the 3 presenters, and the winner for the today's retina surgical war is Dr. Giriraj Vibhute. It was a close fight between the first 2, but the winner is Giriraj Vibhute.
Thank you.
Congratulations, Dr. Giri.
Thank you. Thank you to all the panelists, and gratitude is always there.
So this was a third meeting of Retina Surgical Ward. So all the winners will be awarded in the YOSI Con, and also they will be presenting their videos, or even it might be at other videos as well for the grand finale on the 5th or 6th of the September. The final dates will be announced soon. And thank you all the panelists. Special thank you to Dr. Atul Dhawan, who in a very short notice he could make it and gave some insightful comments for the videos. And thank you so much, Dr. Kaushik and Dr. Devakant, for always being there. Thank you so much.
Good night. Thank you.
Thank you very much.
Thank you.
Thank you,
Thank
Karthik.
you,
Thank you,
everyone. Yeah,
Kaushik sir.
thank you guys. Thank you.
Thank you. Thank you.